Okay, so hello everyone. Good evening. I hope I am audible and there are no audio video issues. Okay, right. So welcome everyone to this session. And at the outset, let me tell you that I'm excited to announce to you that very soon Doc Tutorials is launching probably India's first medicine residency training program. And this program is exclusively curated by a team of super specialist faculties uh, to the medicine residents, the MD and DNB medicine residents. Now, I'm sure all of you know Doc Tutorials. We are having a very successfully running NEET SS program, both for the medical group as well as the surgical group. And we are training students for the NEET super specialty and the INI exams. There has been a lot of request from the students, especially the medicine residents, on a specific training program for residency. So that is how this thought of medicine residency program came in, wherein our attempt is to give you a holistic approach to medicine residency. And rather than any sort of MCQ training here, in this program, we'll be specifically helping you to evolve to better clinicians. And subsequently, I'm sure that many of you might travel the journey of a super specialist as well. But during residency, we'll start from very basics, okay? Like during your residency, you've got to be thorough with the history taking, the examination part, because many a times when you enter residency, uh, it's not just the theory part that creates the trouble. It's often how you approach scenarios, how you make decisions, and also the treatment aspects as well, because you need to be updated. Medicine is an ever-changing science. And this talk, for example, on status epilepticus, which I'm giving. So I have taken this topic even before to medicine residents. But again, there are a lot of changes happening and you have got to be updated as well. And so in medicine residency training program, we'll be giving you the most updated content with respect to the treatment as well in a very simplified manner. Okay. So rather than you putting a lot of effort into the guidelines, then finding out what is most relevant for you, we are trying to make your job easier because we know that in residency, you already have got lots of work. So we are trying to make learning more easier and enjoyable for you all guys. So as I said, the medicine residency training program will be a hybrid course. You will have recorded lectures as well as live lectures. Recorded lectures will be having the theory part or the discussion part, because you have got the your theory exams as well. So you have got to be solid in your theory. So you will have theory lectures, but it will not be just say a routine theory lecture. It will be very clinically oriented, and most of the topics will be scenario based. So we are not just going to pump in lot of information for you to just mug up, but we'll be bringing in scenarios, and it will be mostly a scenario based learning. So the problem solving approach, I think you will be able to grasp by these lectures. And in these series of lectures that we are doing in YouTube, as a primer session, just to tell you what we are planning to do in the residency program. Even last day, Dr. Niyaz sir was taking a session. So it was on the clinical approach to the urinary tract infections, how to make decisions what antibiotic to start at what dose. So all those stuff will be discussed. So as I said, it's mainly a problem solving approach, and it's mainly to evolve you into better clinicians as well. Okay, right. And so today, let me just move on with my topic. And if you've got any queries regarding the program, you can just inform me as well. 1 second. Yeah. So I hope you are able to see my screen. Yes. So let's start the discussion part. Okay. Right. So as you can see in this slide, we are going to discuss a topic which is very relevant from the neurology point of view. And I'll be having a concise discussion on the topic because I know as medicine residents, you do not have too much time to spare and you would like to have things in a concise, crisp format, which is exactly what I'll be doing in this session. So here I'll be discussing on the management of status epilepticus, how to extinguish fire in the brain. So coming to the management of status epilepticus, see, I know that you have read this from probably multiple textbooks and or other review articles, but you would have seen that there is a lot of variation in the actual management protocol in various resources. So as a medicine resident at your age, I was also confused, why is so much of variation? So I think I'll be able to give you more clarity during the course of this discussion on this topic. Let's try to dive more into the topic. And I am telling you already that this is not going to be a super theoretical discussion of status epilepticus. What I am going to teach you is on a day-to-day basis while you take a duty in the emergency department. Because as medicine residents, you will encounter a lot of cases of status epilepticus and how you can manage the patient better. That's what I'm trying to tell you. Okay, right. So this is a WhatsApp group that I have made for the MD and DNB medicine residents across India. So if you are not a member of this WhatsApp group, you please scan the QR code and join the group. So here we have got a team of super specialists who will be guiding you through your residency. We will also be sharing clinical scenarios with you, interesting CT, MRI, the experiences that we have from our routine practice. Let's discuss it together in this group. So I welcome all of you to join this group of MD and DNB medicine residents. So without wasting any more time, let's dive into the topic, okay, of status epilepticus. Okay, right. Uh, right. First of all, what is a status epilepticus? Now, to define a status epilepticus, what majority of you know is that you've got 5 minutes or more of continuous seizure activity or two or more discrete seizures between which there is an incomplete recovery of consciousness. Now, this is the definition which we routinely use in our clinical practice. But if you go according to the International League Against Epilepsy, that is ILAE, the latest definition is that this status epilepticus is defined as a condition that results from either a failure of the mechanisms responsible for seizure termination or from the initiation of mechanisms, okay, which lead on to abnormally prolonged seizures. Now, what is the importance of this new definition? Now, the new definition is more a conceptual definition incorporating the pathophysiology that goes into status epilepticus. So in your body, you've got certain defense mechanisms that will help you to abort a seizure. Okay. Now, in case of status epilepticus, these mechanisms will fail and the initiator mechanisms or the propagator mechanisms will take the upper hand, and this will lead on to abnormally prolonged seizures. Now, when I say abnormally prolonged seizures, I want to introduce two more terms which are actually a part of this definition, and that is the T1 and T2 times. So what do you mean by T1 and T2 times? Now, T1 time for a seizure is the time where you will call this as an abnormally prolonged seizure. That is T1. And T2 time is the duration after which there are long-term consequences. Now, what do you mean by these long-term consequences? Suppose there is a patient in the emergency department who's having a seizure for a relatively longer period. What is the problem? There is a definite chance of a neuronal injury, and there is a chance of neuronal death as well. Okay. And obviously, you will be having alteration of the neuronal networks. Now, this particular time period is the T2 time period. Now, why are these time periods important? Are these time periods important in routine management? My answer is yes. Okay. Now, why do I say so? If you look at the T1 and T2 times for various type of seizures, for a generalized tonic-clonic seizure, the T1 time is 5 minutes. So it is after a seizure that lasts for more than 5 minutes, you say that, yes, the seizure is abnormally prolonged. And this is actually giving you a hint to start emergency treatment for a status epilepticus. You've got to initiate the treatment for a status epilepticus. Now, T2 is actually a red signal. So T2 in tonic-clonic status epilepticus is 30 minutes. So beyond 30 minutes, you are likely to have the long-term consequences, which I already mentioned to you. Now, coming to the focal status epilepticus, where the T1 and T2 time periods are slightly different. So when you look at T1 for focal status, it is 10 minutes. T2, it is more than 60 minutes. So relatively longer duration, T1 and T2. And for absent status epilepticus, the T1 is 10 to 15 minutes. And we are exactly not sure of the T2 in absent status epilepticus. So you've got to be aware of the T1 and T2 times. Now, let me try to substantiate to you the importance of that 30 minutes. Now, what happens is that when a seizure is going beyond 30 minutes, okay, just imagine a patient is there in the emergency department and he's having a continuous seizure. Now, once it is beyond the T1, you're quite sure that, okay, this is an abnormally prolonged seizure. I've got to initiate treatment for status epilepticus. But initially, when there is a status, there are certain compensatory mechanisms in the body which will increase the blood pressure and increase the cerebral blood flow. So the compensatory mechanisms will be active in the initial phases of status epilepticus. But once it goes beyond the T2 time period, what happens is that there is a failure of the cerebral autoregulation. There is a decrease in the cerebral blood flow. There is an increase in the intracranial pressure, and the patient might go to hypotension. So these are the problems that can happen once you cross the 30-minute time window. Okay. Now, as the seizure is proceeding, as the status is proceeding, what often happens is that there is a GABAergic failure, because GABA being the inhibitory neurotransmitter, and there is a glutaminergic hyperactivity. Okay, right. So these mechanisms will propagate the seizure and will, propagate a seizure into a status epilepticus, then to a refractory status epilepticus, and then maybe to a super refractory status epilepticus. Okay, right. Now, well, this slide is going to tell you the importance of time in status epilepticus, because the title of the session was how to extinguish the fire. Remember, you've got to extinguish the fire as soon as possible. And this data will tell you why. See, the mortality of status epilepticus, which is lasting for more than 1 hour, according to the recent literature, comes to about 34.8%. Whereas if a status is terminated within 30 minutes, the mortality is 3.7%. So you can see that is almost a 10 times increase in mortality that you're seeing once the seizure goes beyond the 1 hour time window. Okay, so I hope you got a fair enough idea on why you should be very aggressive in treating status epilepticus and that this is a neurological emergency. Okay, right. Now, let's go to the management per se. Again, as I told you, I'll keep it very concise, crisp. Well, coming to the management part, patient is now in the emergency department. Now, when you see a patient with status epilepticus, number one, stabilize the patient. Okay. Check the ABC, the airway, breathing, circulation. Is the airway patent? Is the patient breathing properly? Or is he having a gasping type of respiration? How is the circulation? Okay. And you keep the patient in the left lateral position. Point number two, well, there is no time in the emergency department for a detailed history. But if there is one point that in the history that you should know as someone who is going to manage status epilepticus in that patient is the time of the seizure from its onset. Now, if you know that for this particular patient, it will actually give you an idea regarding prognostication of the patient and also how aggressive your treatment has to be. So there is one point that you should ask in the history is the time of seizure that the patient has been having. Okay, right. Because the patient might be brought to the emergency department and he might have been having seizure maybe for the last 40-45 minutes. So you have got to understand how long the seizure has been persisting for. You have got to monitor the vital signs. You have got to assess the oxygenation, and you have to put an oxygen mask. Initiate ECG monitoring, which is very important because a patient with status epilepticus can have cardiovascular complications. And not just that, while you initiate anti-epileptics, especially if you're giving the patient phenytoin or fosphenytoin, you have to watch out for development of any arrhythmias as well. Then you have got to check the capillary blood glucose because sometimes hypoglycemia may be the trigger for the status epilepticus. And even otherwise, in a patient who has been having continuous seizures for long, he might have gone into a hypoglycemia as well. So you do not want to cause any added injury to the brain. IV access for blood routines, electrolytes, and toxicology. So you know that these are all reversible causes. If you find a hyponatremia, if you find a hypocalcemia, the management has to be directed at the contributing cause as well. And toxicology screen is also important in the appropriate clinical scenario because, as you know, there are multiple drugs that can precipitate seizures like theophylline, cocaine can precipitate, isoniazid can precipitate, tricyclic antidepressants can precipitate. So these are all very important. Now, after the initial steps, you have to put an IV line and start off with the anti-epileptics. And which is the first line anti-epileptic that should be given? Yes, it is a benzodiazepine. So usually benzodiazepines are the preferred first line anti-epileptic, first line agents for status epilepticus. Why not a drug like phenytoin? It's because of the latency. You want a drug that is going to act very fast. Okay, so there should not be any latency for the onset of action, which is why you are giving benzodiazepines as the first line. Now, this is where you should be cautious. Now, what I am telling you is the doses of the drugs as well. Now, you've got to be very familiar with this. And as a medicine resident, this has to be on your fingertips because you will need this, anytime you take a duty in the emergency department. Now, IV lorazepam, 0.1 mg per kg per dose at a rate of 2 mg per minute. And in a single dose, the maximum you can give is 4 milligram per dose. 4 milligram per dose. Can you repeat the benzodiazepine? Yes. So that means you can give more than 4 milligram, but at a shot only 4 milligram. You can repeat if you want. And when you give lorazepam, it is diluted 1:1, most commonly with a normal saline. So IV lorazepam is an option. You can also, another option is to go for an IV diazepam at a dose of 0.15 to 0.2 mg per kg per dose, and the maximum is 10 mg per dose. You can also go for intramuscular midazolam because sometimes getting an IV access may actually cause some trouble, especially in obese patients. So you might have to give an intramuscular midazolam to abort the seizure, and it is given at a dose of 0.2 mg per kg per dose. And for adults, roughly the dose is 10 milligram per dose, and for children, 5 milligram per dose. And out of all these agents, usually the preferred one is intravenous lorazepam. So you can even use the others, but the trials slightly favor lorazepam over the other agents. Okay. Now, one very important clinical point I want to share with you is when you start a benzodiazepine, you please start it as fast as possible. Okay. Do not waste any time. And also you give the full dose. Now, why I say this is because let's take fast. Now, if there is a delay in administering the initial drug, what can happen is, as status is proceeding, you can have internalization of the GABA receptors. Now, GABA is an inhibitory neurotransmitter. So when there is an internalization of the GABA receptors, what will happen? There will be resistance. A seizure that is persisting for long, then even if you give benzodiazepine, may not respond. So you give it fast before there is any sort of internalization of the GABA receptors, and you give full dose. Do not give half-hearted doses. Please give the full dose. Okay, important. Right. And then another practical point is, see, I told you, you can give lorazepam, diazepam, midazolam. Now let's try to make a quick comparison of lorazepam and diazepam in one clinical context. Now suppose the seizure was due to hyponatremia. Okay, hyponatremia triggered the seizure. Now in this case, you still have to abort the seizure. So yes, it's not just about sodium correction. You have got to abort the seizure immediately. So you give a benzodiazepine. Now when you give a benzodiazepine, then comes the question. Is it enough to give a first-line drug, or should I proceed on to a second-line drug? Now, in that case, if you're giving lorazepam and you're very sure that the cause of seizure is a reversible one, like, for example, hyponatremia, in that case, maybe only lorazepam is enough, because the duration of action of lorazepam is 12 to 24 hours. And if there is a reversible etiology, mind you, if there is a reversible etiology like a metabolic or toxic factors, yes, lorazepam is enough. Okay. But when you give diazepam, there is a problem. Now, diazepam, it is not recommended as the only, that is the sole treatment. The reason is because suppose in a patient with a seizure due to a hyponatremia, I give the patient a diazepam. Diazepam has a rapid redistribution in the adipose tissue, which will shorten its duration of action. So maybe the seizure gets aborted then, but since the patient is at a high propensity for developing the next seizure, in the next few hours, there is a chance of recurrence of seizure. So as a sole agent, diazepam is not preferred. So if you're putting diazepam, you most likely will require a second line agent as well. Okay, right. Now, is there any role for pre-hospital treatment? That is, a common query that you might encounter is, say there is a patient who is a case of epilepsy, and it has been a couple of times that he has had the admissions to the emergency department and the ICU with status. Now, suppose the mother is asking you, doctor, now it has been twice that he developed this problem. Now, if the seizure happens at home, is there any remedy that I can do at home? So is there any importance for pre-hospital treatment? Now, pre-hospital treatment, there is a definite role. Okay. And of late, it is highly suggested that you can give pre-hospital treatment, especially even by the paramedics. That is, you can give the patient intranasal midazolam, which will help to abort the seizure at a dose of 0.2 mg per kg, buccal midazolam at a dose of 0.5 mg per kg, or rectal diazepam, you get as a rectal gel as well, 0.2 to 0.5 mg per kg, maximum of 20 mg per dose. Okay, so I just show you. See, this is just a picture to show you the midazolam nasal spray. And as you can see in this, it is available as metered doses. So you can see it is 1.25 for each dose. So as I told you earlier, if for an adult you are planning to give 10 milligram, okay, I already told you midazolam dose in an adult is usually 10 milligram. So in that case, how many puff you have to give? 8 puff, correct? 8 into 1.25 is 10. And similarly, if it is for a child, 4 puffs into one nostril, okay? So 8 puff into one nostril, okay, in case of adults, and 4 puff into one nostril in case of children. In case the seizure is persisting even beyond that, you can put in the next nostril, the next time you are giving, because you don't want to irritate one nostril alone. But in the first instance, just one nostril is enough in the dose that I've already mentioned to you. Okay, right. So this is about the pre-hospital treatment. Okay, right. Now, what if the first line has been given and if the convulsive status epilepticus is not controlled within 20 minutes of seizure onset? In that case, a second line therapy should be initiated. Now, see, here again, there is a practical problem. So if you ask me, sir, is it always necessary to start a second line agent? See, in common practice, many a times we do go for the second line, okay? But suppose if it is a reversible cause, just like the one that I mentioned earlier on hyponatremia or hypoglycemia, in that case, first line alone is enough. But anyway, if the seizure is persisting with, is not controlled within 20 minutes of seizure onset, definitely you will have to go for a second line therapy, no doubt about it. Okay, right. Now, what are the second line options that you have? Now, anti-epileptics, as we have learned right from our MBBS days, there are a lot of options. So here also as second line, you've got multiple options. So what are the options that you have in hand? Number one, you've got IV fosphenytoin, which you can give. Even phenytoin also you can give. But you know that fosphenytoin has certain pharmacological advantages over phenytoin. So fosphenytoin, 20 mg per kg. The same is the loading dose for phenytoin as well. Maximum of 1,500 milligram. And the rate of administration of fosphenytoin is 150 mg per minute. Whereas in case of phenytoin, if you look phenytoin, the rate of administration of phenytoin is 50 mg per minute. So suppose if it is a 50 kg adult, the infusion will be over in somewhere around 20 minutes. Whereas the same for fosphenytoin, in around 6 to 7 minutes, the infusion will be over. So one pharmacological advantage of fosphenytoin is that you've got a rapid rate of administration. Another point is that when you compare the cardiovascular effects, both fosphenytoin and phenytoin can predispose to arrhythmias. So continuous ECG monitoring is very important. But the chance of hypotension, the patient going into hypotension, is more with phenytoin. So compared to fosphenytoin. Okay, right. And the next advantage is that suppose you're finding securing an IV line very difficult, you can give an intramuscular injection of fosphenytoin, but you cannot even think, not just giving, cannot even think of giving a intramuscular injection of phenytoin, because that can cause massive tissue necrosis. And I'm sure that you would also have heard about the purple glove syndrome that can occur along with phenytoin administration, that is extravasation. Okay, when there is a phenytoin extravasation. So even if you're giving phenytoin, please, make sure, just ask the nursing staff to make sure the IV cannula is patent before giving phenytoin. You do not want any sort of extravasation. Okay, important. Okay, right. Then another option is valproate. Valproate at a dose of 25 to 40 mg per kg at a rate of 10 mg per kg per minute is the rate. And this is very important. It's not just about putting valproate, knowing the dose. You should know the time the infusion should take. Because if you take too much time, then you are allowing more time for the neuronal injury. A maximum dose of valproate is 3000 milligram per dose. And if that is the dose that is given, you roughly will finish the infusion within 30 minutes. Then about IV levetiracetam at a dose of 20 to 60 mg per kg at a rate of 5 mg per kg per minute and a maximum dose of 4500 milligram. So levetiracetam has relatively a broader range. Okay. So I usually give it somewhere between 30 to 40 mg per kg. But in certain scenarios, especially when the seizure has been persisting for long, in that case, you will have to go for the upper end, that is 50 to 60 mg you will have to go for. Okay. Now, of late, lacosamide has also been an agent that has been approved for use in status epilepticus. You can use IV lacosamide 10 to 12 mg per kg at 0.4 mg per kg per minute. Usually 200 to 400 milligram is the dose that is given over 30 minutes. Okay, so these are the usual preferred agents. And if you ask me overall, what are the top three agents? It is fosphenytoin, valproate, and levetiracetam. Not in a top to bottom order, because trials have shown that the efficacy is almost same between agents, and none of the agents is superior in terms of efficacy, except for certain minor differences, which I'll be discussing with you very soon. Okay. Carbamazepine is not commonly given in the management of status epilepticus. It is not having a solution, and it cannot be given as an injection, so it's not preferred, carbamazepine. Okay. Now, if the patient, see, when you talk about status epilepticus, you can have a convulsive status epilepticus and a non-convulsive status epilepticus. In a convulsive status epilepticus, it may be a tonic-clonic one. It may be a focal status epilepticus. Now, if it is a generalized absent status epilepticus, in addition to lorazepam, the preferred second line will be a valproate. Whereas in case of generalized myoclonic status epilepticus, lorazepam plus valproate or levetiracetam, they are the preferred agents. Okay, right. Now, in addition to the agents that I have shown you, you can also try certain other agents, especially where the setting where your IV cannula, you're not able to put it very soon. You can give perampanel or topiramate via the nasogastric tube. Perampanel at a dose of 8 to 32 milligram. You've got tablets available at 2 milligram, 4 milligram, 6 milligram, 8 milligram strengths of perampanel, and topiramate 150 to 800 milligram. But mind you, not just in scenarios where getting IV access is difficult, certain cases of refractory status also, sometimes giving perampanel or topiramate might work. I personally have, experiences with this, as well as there is a lot of literature backup as well. Especially perampanel, I've seen in certain cases of autoimmune encephalitis having refractory status. Addition of perampanel is definitely helping to bring down the the status. And but again, it's not the preferred first line agent, but definitely you can think of perampanel and topiramate as options as well. Okay, so perampanel is acting via the AMPA receptors, AMPA antagonist. Okay, right. Okay. Now, along with that, it is also important to initiate the disease-specific treatment, because suppose if it is a herpes encephalitis, you will have to start on acyclovir. If it might be a meningoencephalitis, antibiotics may be required. Correction of metabolic parameters is required. And in case of a hypertensive encephalopathy or a press leading on to a seizures, antihypertensive medications are also very, very important. Okay, so disease specific treatment is also important, right? Okay, right. And just one point I want to tell you is on the comparison of these agents, which I told you. See, when you compare these agents, if at all someone is asking you that is there any definite trial to show that these agents are having almost similar efficacy, there is a landmark trial, which is the ESSET trial. Okay, ESSET trial, which was done by an Indian. Okay, so okay, so in this landmark trial, which was headed by an Indian, so this trial actually showed that these agents are having almost similar efficacy. Maybe levetiracetam marginally more effective, but again, not a statistically significant difference. But if you ask me, sir, what do you commonly use in your practice? I usually go for levetiracetam as my first choice second line agent, which is also backed up to a small extent by the asset, which shows a slight advantage. That's it. But again, statistically, not much significance between these agents. Okay, right. And these trial actually compared these three agents. Okay, not lacosamide. It's just between these three agents. That is fosphenytoin, valproate, and levetiracetam. Okay, fosphenytoin, valproate, and levetiracetam. Okay, right. Now coming to refractory status epilepticus, so clinical and electrographic seizures, clinical or electrographic seizures that persist after adequate doses of an initial benzodiazepine and an acceptable anti-seizure drug. So remember, even if you have given a benzodiazepine and you have given a second line anti-seizure drug in the adequate dose, mind you, it's not in half-hearted doses, in the adequate dose, that is when you say it is a refractory status epilepticus. Now, once you have labeled a patient as a refractory status epilepticus, now comes the question. Should you go for the next second line agent or should you go for the anesthetic agent? I hope you understood. Like, suppose if I started out the patient with lorazepam and then loaded the patient on levetiracetam, seizure is continuing, and then should I go for the anesthetic agent, or should I go for the another second line agent, for example, a fosphenytoin or a valproate? Now, there is no definite, say, a suggestion on this. There are different viewpoints. If you look through the guidelines as well, there are two important guidelines for the management of status epilepticus. One being the Neurocritical Care Society guidelines, and the second is the American Epilepsy Society guidelines, which you can see are slightly different in terms of their opinion on this as well. But again, you've got both choices. You can go for another second line agent, you can try with it, or you can go for the anesthetic agent as well. Another option is, suppose you loaded with fosphenytoin 20 mg per kg. You can just try topping up with another 10 mg per kg of the same drug as well, which is also a potential option in front of you. Okay, because you remember, when you decide that you're going ahead with anesthetic therapy, you've also got to keep in mind that anesthetic treatment is also associated with complications like hypotension as well. So you've got to keep that also in mind. Okay, now what are the third line agents? Third line agent, you can go for IV midazolam, IV phenobarbital, IV ketamine, or propofol. So midazolam at a loading dose of 0.2 mg per kg, followed by 0.1 mg per kg per hour. Now, every resident is supposed to know this. You can write it in your book. You can just revise it a few times. At least, when you take an emergency duty, you have got to have a chart of the status epilepticus management in case you're not able to remember. This is very, very important because you cannot underdose the patient. So this is usually the infusion rate. You can up titrate it depending on the response. So do not think that this is just a solid figure. You will see even textbooks also differing in the values because you can up titrate these values. So midazolam can be given. Then pentobarbital at a loading dose of 5 mg per kg, followed by an infusion at 1 to 5 mg per kg per hour. IV ketamine at a loading dose of 1.5 mg per kg, followed by 0.01 to 0.05 mg per kg per hour. You can go up to 10 mg per kg per hour in certain circumstances. IV propofol at a loading dose of 2 mg per kg, followed by 2 mg per kg per hour. Now, these are the options that you have got. Again, there is no evidence that, okay, this should be the third line agent that should be superior, that is superior over the others, nothing like that. Each has got its own advantages and disadvantages. Midazolam, if you see, it is a good agent. It is a benzodiazepine. But the problem is there is a problem with tachyphylaxis. So once you go for a continuous infusion, after some time, you can see that the patient might have rebound seizures as well in certain scenarios because of the tachyphylaxis. And also the hypotension is another problem with midazolam. Okay. Regarding the barbiturates, barbiturates also you can have hypotension as a problem. But along with that, this can suppress the immunity. Okay, this is very important. Barbiturates, especially when you give it as a continuous infusion, it is well known to suppress the immunity and it can predispose to infections as well. And another problem with the barbiturates is that it can cause accumulation of the substance. So barbiturates can accumulate, which can lead on to prolonged drowsiness. So you may not be able to distinguish whether it is the drowsiness due to the status or due to the drug. So accumulation is a problem with the pentobarbital, which is not much of a problem with midazolam. Okay, these points are all practically very relevant, in decision making. Now, midazolam, propofol, they are acting via the GABA A receptors. Ketamine is an NMDA antagonist. The advantage of ketamine is that it does not cause hypotension. It is not going to cause hypotension, which is a major problem with other third line anesthetic agents. But again, it also has got neurotoxicity. It can cause increase in the intracranial tension. It can even cause hypertension. It can cause increase in the intraocular pressure. There are problems with this. Propofol, again, the problem with continuous infusion of propofol, especially if you continue it beyond 12 hours, is the development of PRIS, that is propofol infusion syndrome, which occurs due to the propofol affecting the beta oxidation in the mitochondria. So this can lead on to lactic acidosis, rhabdomyolysis, hyperkalemia, cardiac problems and arrhythmias. So that is known as propofol infusion syndrome. So you've got to take that also into consideration. So these are the options that you've got. Now, suppose you have started off a third line agent. When will you think of tapering the dose? I told you can up titrate the dose that I've already told you. Now, when to taper anesthetic therapy? See, absence of clinical and electrographic seizures for at least 24 hours. Now, remember, in any status that is existing beyond 1 hour or lasting beyond 1 hour, it is always advised to have a continuous EEG monitoring. So status that is lasting more than 1 hour, it is advised to have a continuous EEG monitoring, the facility of which may not be available in most centers. In that case, you've got no other option, other than, taking a portable EEG. That is what you can do. When to taper anesthetic therapy is when the patient is having absence of these seizures for at least 24 hours. Because sometimes what can happen is that in a prolonged seizure, after the convulsive phase, the patient can go into a non-convulsive status and the patient might be having some negative symptoms like a drowsiness. You might think that the seizure is under control. So there is no clinical phenomenon, but when you connect the EEG leads, you can see that, yes, there is epileptiform discharge. So there again, you have to take it as a status itself. Okay. So that is when you have got to taper the anesthetic therapy. But again, do not abruptly stop. You taper it. But sometimes if the seizure recurs on tapering the dose, again, you will have to up titrate the drug. Okay. Now, when you give an anesthetic agent, there are how to dose an anesthetic agent. What is your target? See, one target is clinical or electrographic seizures. But sometimes you need to be more aggressive, especially, when you started off a benzodiazepine, still, the patient is showing a ictal activity, then you should go for a deeper level of anesthesia. to get a burst suppression pattern in the EEG, or sometimes even a complete suppression pattern in the EEG. But the problem is when you try to attain a burst suppression pattern in the EEG, you will require a higher doses of anesthetic agents, and you know that higher doses of anesthetic agents are associated with various complications. That is the problem. Okay, so that is very, very important. Okay, now what is superrefractory status epilepticus? Status epilepticus that continues or recurs 24 hours or more after the onset of anesthetic therapy, including the cases where the status epilepticus recurs on reduction or withdrawal of anesthesia. That is called a superrefractory status epilepticus. You've got to be very familiar with the definitions as well. Not just from a theoretical point of view, this can influence your management decisions as well. Now, superrefractory status epilepticus, you will have to go for a what is going to be the treatment? You can go for a deeper level of anesthesia. Maybe you will have to try to attain a burst suppression pattern on the EEG. But there are certain other options as well, because when a patient goes to a superrefractory status epilepticus, you should think, why is the patient going for a superrefractory status? One causes, the seizure was already lasting for a long time by the time the patient came into the emergency department. So the seizure is propagating in spite of you giving all the drugs, because of the reasons that I've already discussed with you. Then autoimmune encephalitis, which is an important cause of status epilepticus. This might require immunotherapy. Methylprednisolone pulse 1 gram IV OD for 5 days, followed by oral steroids, which are given for a period of around 6 weeks may be required. You can think of intravenous immunoglobulin, you can think of plasma exchange, and also the rituximab, especially in autoimmune encephalitis, to the patients might respond to rituximab as well. I've got my personal experiences as well with rituximab, wherein I've got a patient with autoimmune encephalitis. I tried probably multiple anti-epileptic drugs, but once I started the patient on rituximab, yes, one thing is that the disease activity comes in control, and so did the seizure activity. Ketogenic diet, which is a low carb diet. So the ratio of fats to carbohydrates will be 4:1, can be given by the nasogastric tube, which is definitely having a role in the management of especially the superrefractory status epilepticus. Certain conditions like your eclampsia, you can have magnesium as a therapeutic option. Magnesium again acting via the NMDA receptors. Then you've got electroconvulsive therapy, and then hypothermia. Again, hypothermia, it is the evidence is not very strong like the other agents, but again, in desperate situations, you might have to go for hypothermia as well. Now, I told you a majority, 50 to 75% of status epilepticus is the convulsive status epilepticus. What about non-convulsive status epilepticus? Yes, you will manage in a similar fashion, but one point I want to mention to you is about the therapeutic test for a non-convulsive status epilepticus. So how do you identify, is it a non-convulsive status epilepticus as well? You give slowly incremental doses of midazolam. It's not like giving a bolus dose. You give first 1 milligram IV, look at the clinical response, look at the EEG, and you see whether the patient is clinically improving and also the EEG also is getting better. If there is no response, give the next 1 milligram, look at the clinical response and the EEG response. Okay, this is what is called a therapeutic test for a non-convulsive status epilepticus. Okay, right. So these are the points from a management point of view, which I wanted to discuss with you on status epilepticus. And it's very important to have a solid knowledge on this. So what we have discussed today is status epilepticus. So virtually, it's a condition where the brain is on fire. So in neurology, we say that a stroke is like time is brain. Okay, just like a cardiologist would say that time is myocardium in case of a myocardial infarction. But time is brain in case of status epilepticus as well, because this is a condition where the brain is on fire. Okay, and it's a neurological emergency. You've got to be an expert in managing status epilepticus. You've got to be aggressive. Maybe when you take a long case of neurology like a dementia, if you are a cricket fan, okay, you can be a Rahul Dravid. You can take the case slowly. You can take a long history. You can write it down. You can think of the possibilities. You can analyze the case. There is a lot of time. But when you are in the emergency department managing an emergency like status epilepticus, you've got to be very, very aggressive. Okay, like a Sehwag or a Rohit Sharma or a Virat Kohli, you've got to be very aggressive and be fast. Okay, you have to initiate treatment quickly in the appropriate doses. The problem is that if you do not know the doses, then you will have to keep searching, calling your senior. Okay, what is the dose of this? Then you try to up titrate on that dose, not getting control. You again call your senior, you're losing time. So, which is why I have selected this topic just to tell you, yes, we have all learned about status, but we should know what is the accurate dose that has to be given and how fast it has to be given, rate of administration, when to proceed to the next step. All these are very, very important. Okay, so I hope you've got a fair enough idea on the management of status epilepticus. Once again, we are looking forward to interacting with all of you in the residency program. We have got few other sessions also lined up in YouTube. Just stay tuned to the channel. You can just subscribe to the YouTube channel so that you will be getting notifications of the further sessions as well. I think there are sessions by Dr. Karthik and Dr. Vivek, Dr. Kamal sir, Dr. Prashant Gandhi sir, Dr. Hemant sir, Dr. Vijay sir. So all these sessions are lined up, and uh, and I hope you have already listened to the two lectures which are already over by Dr. Mithun sir on the basics of mechanical ventilation, a must-watch video, and a video by Dr. Niyaz sir as well. So that's it. You can join the residents group and let's interact in that group. And very soon the course is going to be launched. It will be up in the app very soon. And further notifications will be in the Doc Tutorials website as well. And in this group also, we let you know once the announcement is made and the course is live. Okay. So thank you so much, everyone, for joining. And in case you have got any queries, you can just approach us. This is my WhatsApp number. I'll just share my WhatsApp number with you: 9447 334944. So in case you've got any academic queries, I'll be happy to help you. So thanks a lot, everyone, for joining. And through the medicine residency program, let's try to make the residency more fruitful for you, and along with conserving your time as well. Okay, because as a resident, I know how hectic residency is. We don't want to bombard you with so much knowledge, but believe me, we are trying to make things easier for you, right from the basics to the advanced. We'll have everything in this course. Thank you so much for joining, and bye-bye.